Hi, I'm Kelly, a registered respiratory therapist with Blue Zone Health. Do you feel breathless much of the time? Are you unsure of how to manage your breathlessness? Is it keeping you from doing all the things that you would like to do? I'm here to help you learn to work with your healthcare team to come up with a plan that will work for you. There are lots of tools, tips, and tricks and breathing exercises that you can do now that will help you breathe easier and more effectively. I look forward to joining you on this journey and empowering you to breathe better.
Hey everyone, and welcome back to another episode of the Cozy Long Lounge. I'm here with Kelly and Gina today.
Good afternoon, good morning, wherever you are in the world. Welcome.
Welcome everyone to the Cozy Long Lounge. I'm so glad you're here.
Today we're going to be talking all about pulmonary fibrosis. So we've been on this journey to hit every single pulmonary health disease, whether it's short-term or long-term. So today we're talking all about pulmonary fibrosis and kind of getting into the nitty-gritty about it.
I'm so happy to have Kelly by my side today because she's the pulmonary fibrosis expert. And I'm so looking forward to hearing her talk about this tonight.
Well, pulmonary fibrosis is a very complicated disease. There are many forms, and there is one form called IPF, which means Idiopathic Pulmonary Fibrosis, which just means we don't know what caused it. There are several subsets of pulmonary fibrosis that fall into different categories, which I'll pull up and show everybody in a second. But essentially, it's the same thing happening. The lungs are just very stiff. So if you think about it, when you take a deep breath in, your chest is able to expand. As we exhale, it contracts. And people with pulmonary fibrosis, it's almost not so much at the alveolar level, but the interstitium, which is kind of that connective tissue that's all in between the alveoli. And I know when we see pictures of lungs, they look like perfect little grapes, but there's something holding those together, and that's called the interstitium. And what happens in pulmonary fibrosis is that interstitium gets really thickened and really stiff, so that people are trying to take a breath in, except that interstitium is like cement. They just can't seem to get a deep breath in all the way down. And then they have no problem exhaling because everything just collapses right back down. So it's kind of the opposite of what we've been talking about, the COPD and the emphysema types of diseases. And let me just pull up a picture here, if I may. I'm going to share my screen. In a healthy lung, these are the air sacs. This is your terminal bronchiole, and you have the little air sacs. And this doesn't really show the interstitium, the connective tissue that's in the air spaces. And so in this picture on the right, this is what pulmonary fibrosis looks like. So they've got that thickened space in there that just makes it really difficult to take a breath in. And in addition, the air sacs get distorted. And on top of that, and I'm going to show you another picture here. So if you have if this is one little air sac right here, if those alveoli are thickened, the oxygen can't get across that and the carbon dioxide can't get across that. So it's almost as if those airways are thickened and it's blocking anything from hopping across that tiny little membrane to get oxygen into your bloodstream and get carbon dioxide out. And so that, in a nutshell, is fibrosis. And I just want to pull this up. Don't worry, you don't have to memorize this, but this is all the different types and subtypes of pulmonary fibrosis. And the only reason I show you this is because the average amount of time from, let me stop sharing my screen here. The average amount of time from when a person first starts to feel that shortness of breath to an actual diagnosis of a subtype of interstitial lung disease is 6 to 7 years, which is a really long time, and it's really frustrating. And many patients with fibrosis start out the same way. They think, oh, I'm just getting older. I need to exercise more. That flight of stairs is getting harder and harder. And they don't really connect that they have a lung disease, especially because fibrosis happens a lot in non-smokers. So smoking will give you a pulmonary fibrosis at times, but not all smokers get fibrosis, and not all fibrosis patients ever smoked. And so there's a couple of concurrent things that may have caused it, but in the end, we really don't know exactly what causes fibrosis. And so that's what why it takes so long to get from doctor, I'm feeling short of breath, and you go through a pulmonary function test, which may or may not show anything. You do a 6-minute walk test, which at that point may be borderline, and it's a very progressive disease slowly. Anything else you girls want to add?
You are the expert on this. I think everything so far has sounded awesome. You know, like you said, it can be really frustrating, especially with this, with pulmonary fibrosis, but with any chronic lung disease, because it develops so slowly over time that you kind of have these years right before you maybe qualify as having that diagnosis where you know something's up, but it's just not quite there, and it can be really frustrating.
Under the category of advocating for yourself, I have so many patients that have come in with fibrosis, finally was diagnosed, but they come in, they say they went to their doctor, they did a pulmonary function test, and they said, you're borderline this, 6-minute walk test, you're borderline that, here's an inhaler, go home. And people with ILD do not need inhalers. This is not about relaxing the smooth airways. This is about the scaffolding in between that's getting stiff, and inhalers don't do anything for that. And I reached a point, I thought, if I see one more patient with fibrosis come in with 3 inhalers, I'm going to throw myself out the window, because there's no need for that. So being an advocate for yourself, if you feel like inhalers aren't doing it for you, if you feel like you're slowly getting worse, go back and say, I need you, doctor, to dig deeper, really dig deeper.
Much of the time, our pulmonary fibrosis patients get mislabeled as COPD. I even had one lady that was clearly pulmonary fibrosis. She knew she was pulmonary fibrosis, kept having COPD on her chart, and she just said, I forget it. Just people just understand COPD better. I just have COPD. And they're very different, very opposite conditions.
Mm-hmm. So there are a couple of causes that we do know. We don't know the exact subtype that it leads to, but there's a preponderance of people who have birds at home. So if you keep parrots, cockatiels, finches, certain birds, when they groom themselves with their beak running along the feathers, they let go of a really, really fine dust. We just call it bird dust, for lack of a better term. And the other thing that happens is when they sit on their little perches and they go to the bathroom, that lands on that dust and it gets everywhere. And you can't see it, you can't feel it, but that dust is lodging itself way, way down into the airways. So in the same way, if you work with asbestos or silica or things like that, you oftentimes can't see it, but it is there working its way down into your lungs. And then the other thing that happens is people often have an autoimmune something or other that's linked to that, whether they have arthritis, scleroderma. Those things can attack lung tissue. For a long time, people thought that somebody who had reflux, GERD disease, or any kind of acid reflux, they thought that maybe the reflux in people's sleep was working its way down into the lungs, which is a possibility. And so, yeah, those are kind of some known causes. And I know people love their pets and they say, I can't get rid of my birds, but if you only knew what it was doing to you.
I had never heard that before.
That's a fascinating story.
Hi, friends. This episode of the Cozy Lung Lounge is brought to you by Hootenanny Joy, where your health and wellness take center stage. At Hootenanny Joy, we know how overwhelming it can be to stay on top of your health, especially when life gets busy or chronic illness adds challenges. That's why we've created self-study programs designed to meet you right where you are. These programs are simple, flexible, and packed with tools to help you thrive. And they come with something extra, access to a live health coach. That's me, to guide you every step of the way. Whether it's improving your sleep, learning to nourish your body, or managing stress, our programs combine proven science with practical, real-life strategies. You can work at your own pace, get the answers you need during coaching sessions, and feel confident you're making progress. Ready to take that first step? Visit hootenannyjoy.com to explore the programs and choose the one that fits your journey best. Hoot Nanny Joy, because your health deserves a little joy.
So in addition to that, what does a doctor look for? So again, in the category of misdiagnosis, besides usually sending you for a 6-minute walk test and a pulmonary function test, if they suspect or you suspect any kind of fibrosis, they need to send you for a CT scan, but not just any CT scan. It needs to be called a high resolution CT scan, so they can actually get a good look at what's going on really deep into your lungs and into the scaffolding, into the interstitium. The other thing is your breath sounds. So I've always had an issue with the way people listen to breath sounds, because what happens in breath sounds in fibrosis is you get almost what we call an inspiratory squeak, but you don't hear it until the end of inspiration. So if a doctor says, okay, take a deep breath, and he here and here and here and here, and he's moving or she is moving too fast, they will miss that classic end inspiratory squeak or end inspiratory crunch almost. It's kind of a combination. I don't know how else to describe it. Once you hear it as a respiratory therapist, you'll never forget it.
If you take your hair and just kind of finely rub it between your fingers next to your ear, that can almost be a little bit crackly. And so
It's a little
sort
bit
of like
but that
Velcro. That Velcro sound when you rip a piece of Velcro. That's what you're going to hear at the very end of the breath. And Kelly's right. You got to listen all the way at the bottom of your lungs to hear that.
Yep, and all the way to the end of the inspiratory phase. And most doctors are in a hurry, and you have to say, hey, I need you to take a closer listen. You need to listen longer just to make sure. And some other signs and symptoms, the dry cough. It's just annoying as all get out to have this dry cough. There's nothing to cough up. There's no secretions. No one knows why that dry cough happens. The best thing you can do is I think there's one brand that is in the forums and in the groups called Fisherman's Friend. I've never seen it out here. It might be an East Coast thing, but Fisherman's Friend lozenges. And those seem to help soothe and ease the cough a little bit. The thing that you can get, and this gets into some funky territory, but the thing that you can do is low dose opioids, like a low dose any kind of opioid, not a synthetic, but a low dose morphine, for example. And a lot of people say, morphine, I can't take that and go to work. You're taking a really, really low dose, but that helps to somehow relax that interstitium so that you can breathe a little bit deeper. So you may have to ask for that as well.
This is also interesting to me. I haven't learned very much about this in depth.
It's a lot. There's a lot that goes on with interstitial lung disease that a lot of people, just because it's rare, although it's becoming more and more common, but because it's rare, and a lot of people just think, oh, lung disease, smoking, this, and it's not that at all. One of the signs and symptoms you may have is clubbing of the digits, and clubbing of the digits happen when you're chronically low on oxygen. And I always tell my interstitial disease patients, you need to wear your oxygen. I know you hate it. I know it's inconvenient. I know you don't like it. And we have a whole class on oxygen that we do. But the nail clubbing, the clubbed digits happen when you're chronically low on oxygen. So please, 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 if you've been prescribed oxygen, wear it, especially when you're active. Don't take it off to go do something and put it on to sit on the couch. It's the other way around. Put it on to do something. And then if your saturations are good sitting at rest, you can take it off. Most people do it backwards. So let's see, we talked about the high resolution CT. Sometimes they'll do a biopsy. Biopsies are invasive. They should be doing the high res CT first. The 6-minute walk, again, not just walking around the office for 2 minutes to see if you desaturate, because what will happen then if they mistake you for a COPD patient is you'll go home on 2 liters of oxygen, and you will quickly discover that is not enough to keep you saturated. So buy a good pulse oximeter, do the full 6-minute walk test, and ask for it to be done with what's called with titration. And what that means in a nutshell is if you have interstitial lung disease or pulmonary fibrosis, and I'm the one doing your 6-minute walk test, and you're on 2 liters of oxygen because that's what your doctor said you needed, and you and I start walking and we're 30 seconds in and you've already desaturated, I'm going to sit you down. I'm going to put you on 4 liters and we're going to start the test over. And if on 4 liters you desaturate again, I'm going to sit your butt down and I'm going to bump you up to 6 liters and we're going to start over. So this is a 6-minute walk test with titration where we don't just guess at what you need. We actually figure out you need 15 liters. And most patients, when I tell them 15 liters, are shocked. But my concentrator only goes to a setting of 5. And that's the hard conversation about now you need tanks. Nobody wants tanks. Nobody wants to drag them behind you. But honestly, that little cute little concentrator isn't going to keep up with you. And you don't want to damage your heart.
Boy, I see this time after time. I think I just saw this in the past week where a woman had a portable oxygen concentrator that was dropped off for her. And I asked her, has anybody ever tested you on this particular device? And she said, no. Well, if you've got pulmonary fibrosis, chances are those pulse-driven portable oxygen concentrator devices may not hold you, particularly as your disease progresses. So it's important not just to have the 6-minute walk test with a titration of continuous flow oxygen. If you're prescribed pulse dose oxygen, you need to have a test done on that one also.
And again, advocating for yourself because your doctor thinks you have COPD and you'll do just fine on a 2-liter pulse dose, but that's not the case. You need to get into pulmonary rehab and learn how to work with what kind of oxygen that you need. You need to learn how to work around what you need at rest, what you need with mild activity, and what you need with exercise. And yes, you can exercise, even though you need 15 liters. We have special oxygen delivery devices. My favorite is the pendant. The pendant has a little reservoir so that you always get all the oxygen that you need. It's a conversation nobody wants to have, but it's so important, especially if it comes to the point where you're thinking about a lung transplant. And I'm going to tell you straight up, I'm not going to sugarcoat it, but if you want a lung transplant, if you're in that category where you qualify, the number one thing you have to do is keep the rest of your body healthy. And if you starve the rest of your body for oxygen, you will not qualify. If any of your other organs are kind of semi not doing well, you will not qualify. And that's why pulmonary rehab is so important, because you've got to keep yourself strong before the transplant so that when you are able to come back to rehab, because you will after the transplant, you've got some muscle, you've got some endurance, you've got some strength. And you didn't starve your body for oxygen, so you don't have any kidney, liver, or heart problems. And so, not to scare anybody off, like I said, I'm not going to sugarcoat it, but I've had heartbreaking, stories of people who let themselves run around in oxygen saturations in the 60s and 70s. And when it came time to be evaluated for transplant, they didn't qualify because they had borderline kidney, liver, or cardiac damage. And all that was preventable if they had just sucked it up and dragged a tank behind them for a while. And I know nobody wants to do that. I sure wouldn't want to do that. I empathize, but at the same time, that's your best friend.
Absolutely.
Yeah, Kelly, years ago, we always prescribed steroids for pulmonary fibrosis. Do we use steroids any longer?
Not really. I mean, the thing about steroids is they give you kind of they help with inflammation, which is definitely what's happening here, but steroids don't help the way they should with fibrosis patients. There's a couple of drugs that are out. Ofev is one, Esbriet is another. There's a new one that just came out that just got approved called Jascade. Jascade is having good luck because it's got a lot less GI side effects that happen with it. Those are the 3 things. I mean, you can try a course of steroids, and if it helps you feel better for a little bit, that's great. But remember to wear your oxygen.
It's important to know that those new drugs that she mentioned really don't fix the pulmonary fibrosis. They just slow down the rate of progression, so you get more time. But they're not going to fix the problem.
Right. Well, this is a progressive disease, and so it does slow it down. But they're having the clinical trials with Jascade really slowed it down. But that will give you more time to get in shape, get your oxygen needs done, get into pulmonary rehab, get strong, right? Get ready. And then I can do a whole segment on transplants as well. Transplant is a very personal choice. So if you're going down that road and you're at a point where you're looking at a possible transplant and you decide that you don't want to do that, that is okay. You get to choose. You will be kind of pigeonholed into this thing. Well, now you got to do this, and now this is happening. So, this is your option. But there are some people who have said no, thank you.
Yeah, if you say no, thank you to transplant, there are services like palliative care. It's not hospice, but it will help you manage the symptoms as best you can while you have that pulmonary fibrosis and are working through the treatment.
There's a lot of people that go to one lung transplant center and are turned away, but they'll go to another one and get accepted, which is odd. So if you can do it, if you don't like what your doctor's telling you over here at hospital A, you can always go over to hospital B and see about their transplant program. Each individual hospital that does transplant will have their own program.
And Bob Rollins, he came on here before and talked about his experiences. He did not have pulmonary fibrosis, but he did end up receiving a double lung transplant. And he kind of goes into everything that he dealt with and kind of explains what he went through afterwards. They really do try to get you up and moving pretty quick. But it's really interesting to listen to somebody who's gone through it because it gives you a better idea of, hey, this may be scary, but if this is something I'm considering, then it is really good to hear from other people who've gone through it, who say, it sucked for a little while, but I got through it. And if that's something that you decide to do, then you can get through it, because it doesn't even sound like something that should even be possible. And I'm so glad that it is, because it's made a really big impact in a lot of people's lives.
One thing I'd like to mention here, because it's so important to pulmonary fibrosis patients, is access to oxygen. There's a bill out there called the Supplemental Oxygen Access Reform, or the SOAR Act. And it's still out there trying to get better access to oxygen systems, the kind of systems you need to deal with the kind of pulmonary fibrosis that you have, access to education and other sorts of treatment options. So that would be worth looking into, is the SOAR Act, and talking with your legislators. That's something that you support.
I just learned today also, if you're a Kaiser patient, Kaiser just switched off their oxygen service from Apria to another company. So hopefully that will make life easier for some people. But I could talk about ILD and IPF for days. I'm going to cut it here because otherwise you'll be still listening to me tomorrow. So thanks for joining us, everybody.
Yeah, well, good job, Kelly. I actually learned quite a bit about pulmonary fibrosis today that I didn't know. So I hope everybody enjoyed this episode.
Yes, I hope you, as anything left you puzzled, leave us a message and we'll be happy to clarify in our next episode.
All right. Thanks, everybody, for joining. We'll see you next time.
Bye, everyone. Living with a chronic respiratory condition doesn't mean giving up the things you love to do. At Blue Zone Health, we're here to help you breathe easier and rebuild your strength. Our online cardiopulmonary rehab program offers tailored exercises, self-management training, and expert support from certified respiratory therapists. Accessible anytime, it's designed to reduce breathlessness, improve lung function, and empower you, all while connecting you with a supportive community. Visit bluezone.health and take the first step towards stronger lungs and a healthier future. Blue Zone Health. Breathe better, live better.